You are live now, sir.
Sure. Good evening, all the doctors, and I'm glad to meet you all and hope you all are fine and healthy. Let's start this evening and talking about this program. Lupin has always been a catalyst and front runner in fostering the scientific and advanced medical knowledge by partnering with the leading associations and universities across the world. Continuing our endeavor, today we are proud to share the international webinar of the ADA Self-Assessment Program 2022, which is an academic symposia and a case learning module wherein all SCPs like you will get an opportunity to interact and learn from best of the faculties whom we will meet in some time now. And I'm proud to share that Lupin has exclusively partnered with ADA to bring this advanced medical knowledge to distinguish SCPs like you from ADA. And it is my pleasure to be part of this forum, which is graced by the presence of our distinguished faculties. From international, we have Dr. Antonio, and the Indian faculty, we have Dr. Uday Phadke sir. So both of them, they'll definitely take you through the respective talks and the session today. But before we start, I once again welcome you all for this endearing academic session. And talking about a quick brief of Lupin, the pursuit of excellence in the field of medical and better patient health outcome has always been our leading performance. And the Lupin has definitely transformed into a leading global pharmaceutical organization with a strong footprint in US, Europe, Asia, in addition to India. And Lupin is one of the preferred partners trusted by all the medical fraternities across India and professional bodies and peer organizations who partner with us for marketing in licensed brands and bringing them closer to the patients. And Lupin is also a forward-looking organization which believes in bringing innovation in patient treatment and creating a conducive ecosystem. Now, in anti-diabetic space, Lupin has consistently maintained the leadership position and having a complete basket of OHS as well as insulin for the benefit of the patients, and we shall continue to contribute to the well-being of the patients in years to come. Now, without taking much time, I would like to conclude this by thanking you all once again for joining here and taking your time, and look forward for your active participation in this today's event. Stay safe, take care. And with this, I would now hand over the session to Dr. Kunal, who would introduce our eminent faculties now. Over to you, Dr. Kunal.
Thank you, Sumit, for the kind introduction. Well, good evening once again, and welcome all of you for today's ADA webinar session. Well, myself, Dr. Kunal Sonone, and I'm from Lupin's Medical Services team, and will be the today's moderator for the session. Well, as we know that diabetes is a chronic and debilitating disorder, and with various complications earlier as well as in the chronic long-term treatment management is required. So there is an approach of management, and the approach has to be modernized and should be as per the patient requirement. There are different phenotypic approach with different phenotypic patients where the approach should be individualized. For that, today we have two eminent speakers to provide the insight and guidance about the modern approach as well as management of type 2 diabetes patients. With this, I would like to introduce one of our eminent speaker, that is Dr. Antonio Ceriello.
Hello.
Yes, I hope this screen is visible. Can you see the screen?
Yes.
Yes. So, inviting Dr. Antonio Ceriello. He is a research consultant, Italian Ministry of Health, IRCCS Multimedica, Milan, Italy. He is a chair, Diabetes and Cardiovascular Disease Study Group, European Association for the Study of Diabetes. He is a professor. Ceriello has been a consultant of National Institute of Health, USA, for the program of research in the year 2003-2005 related to cardiovascular disease and type 1 diabetes. and member of Writing Committee of American Heart Association of the Guideline on Acute Hyperglycemia and Acute Coronary Syndrome. Currently, Dr. Antonio Ceriello is the chairman of the Diabetes and Cardiovascular Disease Study Group of European Association of the Study of Diabetes. He is also involved as an expert in the ESC 2020-2022 program for the training of the European cardiologists on the use of new anti-diabetic drugs. With this, I would like to invite Dr. Antonio Ceriello and request to take the control of the dice. Over to you, Dr. Antonio Ceriello.
Good evening, and thank you very much for the kind invitation and for the opportunity to share with you something really relevant in the modern management of diabetes. I will be focused on more specifically what means today a comprehensive management of hyperglycemia in diabetes. Of course, I believe that I'm speaking to experts in diabetes. So I will also think that the first part is just a very short introduction on what we already know, but it is really relevant for what I'm going to say later. So please pay attention also to this. We know very well that the first demonstration that hyperglycemia can be considered an independent risk factor for cardiovascular disease in diabetes is coming from the DCCT EDIC study. I mean, EDIC is the long-term follow-up of the DCCT. This study clearly emerged that the intensive management of hyperglycemia can reduce the risk also for cardiovascular disease in this kind of diabetes. It is very relevant to note that when we speak about the type 1 diabetes, we are speaking about people almost young, not having other comorbidities or other risk factors usually. So they are not obese, they are not dyslipidemic, they are not hypertensive. So what we see in terms of effect of hyperglycemia on cardiovascular risk, on cardiovascular disease, is only due to hyperglycemia. So this was the proof, direct proof that hyperglycemia is an independent risk factor also for cardiovascular disease and not only for microangiopathy. Very similar was to demonstration in type 2 diabetes coming from the UK PDS and from the follow-up of this study. And it was clear that also in type 2 diabetes, the control of hyperglycemia can prevent cardiovascular disease, also in type 2. So, and because some studies were unable to show that an intervention on glucose control can reduce the risk of cardiovascular disease in type 2 diabetes with the long duration of diabetes. I'm speaking about the advanced VADT and the ACCORD trials. It was questioned if a good control hyperglycemia can contribute in such population and also to prevent cardiovascular disease. But if you look at this meta-analysis, pulling all the data, it is clear that controlling hyperglycemia can prevent at-risk myocardial infarction in people with previous cardiovascular events, not affecting at all the all-cause mortality, which was the cause of stopping particularly the ACCORD trial. According to this evidence, we can believe that good glucose control can contribute to improve the prognosis for cardiovascular risk. On the other hand, also we can conclude that because in all this study, A1C has been used as a gold standard in order to evaluate the overall glycemic control, glycated hemoglobin should be enough as an indicator of overall glycemic control in diabetes, particularly according to this well-known study, showing a direct correlation between A1C and fasting glucose. However, if I told you, type 1 diabetes does not have comorbidities or other risk factors. So if somebody with type 1 diabetes has an A1C at target for the life or the life, if hyperglycemia is an independent risk factor, the A1C is enough to understand the overall glycemic control in this period. You should think that no one complication could be raised in these people, but this is not true. Looking at the data from the Swedish Diabetes Registry, the Swedish Diabetes Registry is very well known all around the world because it's collecting data from all this population in Sweden. So it's a very comprehensive database. And looking at this paper published using the database of the Swedish Diabetes Registry, you see that it's not true that even when type 1 diabetes is under very well controlled in terms of A1C, the risk for the complications, particularly for cardiovascular complication, remains, not only remains, but it's almost twice as in the controlled people. So we can conclude that clearly A1C is not enough to explain the risk for diabetic complication related to hyperglycemia, including the cardiovascular ones. So if A1C is not enough, we have to look at other aspects of hyperglycemia. Maybe you remember that particularly after the meal, hyperglycemia in people with diabetes increases a lot. And this increase, this specific increase, has been suggested to be very dangerous for people with diabetes. And in 2008 and updated in 2011, the IDF settled specific guidelines on this topic. And the recommendation, the most important recommendation was that targeting both postprandial plasma glucose and fasting plasma glucose is an important strategy for achieving optimal glycemic control. What happens, however, in clinical practice, that usually we measure postprandial hyperglycemia after 2 hours, while evidence is emerging that what happens after 1 hour after a meal or after an oral glucose tolerance test, an OGTT, maybe is more important and more dangerous than what you see after 2 hours. Why? There is a very simple explanation. The explanation is that usually at 1 hour, glycemia is higher than at 2 hours, and higher is glycemia, higher is the risk for the damage. So this is a very simple explanation, which has been already also demonstrated by several studies. But what is really fun, in my opinion, is that while we are used to measure postprandial hyperglycemia after 2 hours, the existing guidelines are already suggesting something else. Particularly, have a look at the ADA, AAC, IDF guidelines. You see that even suggesting, recommending different targets, the timing of checking glycemia is never at 2 hours, but always or at peak or between an hour and a half, but never at 2 hours. So we already have the guideline suggesting an earlier check of PPG than not at 2 hours, but we are almost always, like clinical practice, ignoring this guideline. These are the data which now probably will not surprise you anymore. But when these were developed, it was many, many years ago, at the beginning of using a CGM, they were quite astonishing because we measure the continue using a CGM, the glucose over 24 hours in people with type 1 diabetes, having very good A1C. You see, the median was 6.7, so very good. But when we had a look at the profiles of glycemia over 24 hours, you see here, the situation was completely different. And the glucose glycemia was going up and down in this period. And we have evidence, particularly coming from this first study published almost more than 20 years ago by an Italian group in Verona, that glucose variability, also in terms of fasting glucose variability over time with a follow-up of 10 years, is an independent risk factor for cardiovascular mortality. Something which has been confirmed in the post-hoc analysis of several trials. You see that in ADVANCE, in the DEVOTE, the ADT, NEMPOREG, NOLAT, and the ACCORD, the post-hoc analysis of this study all were confirming that glucose variability is an independent risk factor for diabetic complications. But what is really intriguing is what we just recently published, just last year, again, using the database from the Swedish Diabetes Registry, and looking at the effect of A1C variability on the development of cardiovascular complications. What we found was, okay, we were able to confirm that higher was glucose variability, higher was the risk for almost any kind of cardiovascular complications. But surprisingly, the situation was even worse in people having A1C at target. So evidence suggests that in people having an A1C at target, if they have high glucose variability, they are even at higher risk of developing particularly cardiovascular complications. Why? There are several possible explanations. One is that there is a direct effect of glucose variability on the cardiovascular system. Another one, which I will touch a little bit later, is that probably high variability of glycemia is linked to higher risk of hypoglycemia. And in this review, we were able to summarize all the aspects of glucose variability and its impact on the development of diabetic complications. And also it's important to note that even it's quite complicated to give a really some cutoff, well-defined cutoff in order to define glucose variability. In this consensus published in 2017, a cutoff of coefficient of variation between 33 and 36% has been suggested to be considered in the good one, meaning that it's acceptable, that should be considered acceptable, a coefficient of variation of 33-36% in order to consider glucose variability in a good situation. But recently, another marker, let's say another aspect of glycemia raised a lot of interest, the so-called time in range. The concept of time in range itself is not difficult to understand, meaning how much time the patient spent in the normal range of glycemia. However, for pragmatic stuff, for pragmatic approach, it has been decided to have a different range of, and was not really in the normal range, but to accept as a range of a time of this TIR, a glycemia between 3.9 and 7.8 millimole liter. And this is really impacting in clinical practice. Here you have the evidence of 3 different situations in 3 different patients, all having the same A1C, but different periods of time in range. And you have an optimal situation when the time spent in the range is higher, a very poor situation when the less time in range is spent during the time. But there is also another evidence coming out from this data. You see on the left side that what you can catch using SMBG. On the right side, what you can get using a CGM. Clearly, you see the huge difference between the two approaches. You simply using SMBG maybe is not allowing to see all the profile, the complete profile of glycemia over time, and the risk is to not catch episode of hypos as well episode of very high hyperglycemia. So clearly, if you want to study the timing range, the best tool is to use a CGM. And evidence is already coming out that the timing range is correlated to the risk of complications. Lower is the timing range spent by patient, and higher is the risk for complications, including cardiovascular complications. When we speak about glucose variability, I already anticipated, we speak also about the risk for hypoglycemia, because the variability, high variability is linked to very high risk of hypoglycemia. And we will know very well that hypoglycemia is an independent risk factor for complications, particularly for cardiovascular complications. Probably what is less known is that hypoglycemia is also a pro-atherosclerotic factor, meaning that any episode of hypos activates the same pathway activated by hyperglycemia and accelerating atherosclerosis. So any episode of hypoglycemia must be avoided not only because it's very risky and very dangerous, but also because it's activating in long term the process of atherosclerosis. And finally, there is another aspect of hypoglycemia, very relevant and I'm sure less recognized, is how you must recover from hypoglycemia. I'm sure that the first goal of recovering from hypoglycemia is to increase glucose. It is a so risky situation. And very often, hypoglycemia is a recovery inducing in hyperglycemia. In this study performed in animals and the cells, it was produced in hypoglycemia, and then this hypoglycemia recovered producing or normal glycemia or hyperglycemia. And you see that when hyperglycemia followed the hypoglycemia, there was an overgeneration of free radicals, which is like a ischemia, the perfusion effect that you can have at the level of the heart during a myocardial infarction. When suddenly you reopen the arteries and the oxygen goes, you can produce an overgeneration of free radicals. And the same happens when you recover from hypoglycemia producing hyperglycemia. And unfortunately, this happens not only in the cells and in animals, but also in humans. We were able to show that inducing hypoglycemia in both normal people or people with type 1 diabetes, and recovering, producing a hyperglycemia, you see the worsening of endothelial dysfunction, of inflammation, oxidative stress generation induced by recovering with hyperglycemia. So in clinical practice is something very complicated, but should be avoided to recover hypoglycemia producing an hyperglycemia. Which mechanism are behind all this story I shared with you? It is well known, according to the study of Michael Brownlee, but also to many studies of our group, that hyperglycemia can lead to complications because it's able to produce at the mitochondrial level an overgeneration of free radicals, particularly of superoxide anion. And you see here all the pathways activated by this single production of a superoxide anion, leading at the end of the day at the appearance of diabetic complication. all I have described can fit with the risk of increasing the complications? It's very simple. All the pictures, all the aspect of hyperglycemia I have described, they can activate equally the same pathways of a chronic hyperglycemia. So it's not surprising that when we have an increase of postprandial hyperglycemia, an increase of glucose variability, and hypoglycemia, and so on, you can have an increased risk for complications simply because you activate the same pathways activated by chronic hyperglycemia. So in the last years, we had the perception and the meaning of glycemia has changed a lot. You see here that for years, our gold standard, a unique way to measure glucose control, was to use A1C mainly. But in the end, we had evidence related to the value of 2-hour postprandial hyperglycemia, 1-hour postprandial hyperglycemia, hypoglycemia, and so on, until we got the evidence about time in range. So the concept of hyperglycemia has profoundly changed over time. And today, we can say that if you want to have a perfect modern management of hyperglycemia, you must pay attention not only to A1C and fasting blood glucose, but also to time in range, short and long-term glucose variability, 1-hour and 2-hour postprandial hyperglycemia, and to try to get all these, avoiding hypoglycemia. And if hypoglycemia happens, you have to pay attention how to recover. I understand it's very complicated in the clinical practice to pay attention to all this. On the other hand, this is the evidence. The literature is there, and we cannot ignore what has been already demonstrated and exists in the literature. But also we have several tools which can help to try to keep the glucose control, to get a comprehensive glucose control. We have a new kind of insulins. We have the new drugs. We are also have been demonstrated to be able to reduce glucose variability to improve time in range, and particularly the new technologies which are very helpful on all these aspects of these new aspects of hyperglycemia. So in conclusion, I believe this is the well-known ADA-ESD algorithm. And it was very relevant because for the first time, it has been suggested to pay particular attention to the presence of cardiovascular risk or the risk for nephropathy. On the other hand, also glycemic control was not forgotten. It's still there. Diabetes is characterized by hyperglycemia, and hyperglycemia must be controlled. What, in my opinion, has to change is the concept of the meaning of what means today a good glycemic control. And a good glycemic control is really to pay attention on all the aspects of glycemia I have just described. So I think that we can conclude that the control of glycemia and diabetes is more and more challenging, but it's very important that we know this. We try to do our best in order to preserve our patients from developing complications, and particularly to try to guarantee a good quality of life. I believe that nobody is interested to live longer having let's say, having the need for dialysis, having had a stroke, myocardial infarction without legs. So in my opinion, we must pay attention what the advancement of the science is demonstrated in order to improve the possibility of having a good quality of life for our patients. Thank you very much for your attention.
Thank you, Dr. Antonio Cerello, for the enchanting session. So it's wonderful that you have elaborated a lot of things, not only the hypoglycemic events and the time in range CGM management, but the other factors like glycemic variability and the pro-atherosclerotic events that is related with the hypoglycemic events. So with this, I request to our attendees to provide the question in the chat box which is provided, and I would like to request introduce one of the another speaker, that is Dr. Uday Farke sir. So let me introduce. So here, Dr. Uday Farke sir doesn't require much more introduction. He's a GM. He's a MD, DNB, DM, FAC Fellow of American College of Endocrinology. Is a recipient of the prestigious Srimad Bhandarkar Award for the academic excellence in the DM endocrinology exam, and awarded a special citation by the Bombay University for high score. It's contributed research papers, reviews to journals and chapters to RSSDI textbook and Endocrine Society manual. Is a part of the team awarded the Vivian Fonesca Scholar Award by the ADA in 2016 for a study on bariatric surgery, Cosmet, and also he's an avid high altitude trekker and mountaineer. So with this, I would like to request Dr. Uday Farke sir to have the presentation. Over to you, sir.
Thank you. Thank you, Professor Antonio. That was a very lucid, very concise, and very precise presentation highlighting several facts about treatment of diabetes. And I would like to take this up from there, and I would like to share my slides as well. And going forward, as up to what Dr. Antonio said, we're going to look at some of the perspectives from an Indian viewpoint about the management of glycemia. I'm not going to read out the slides because they're very clear, but I'm going to just tell you the nitty-gritty of what we in India as diabetologists, how we should approach our patients with type 2 diabetes. These are the things that we are going to look at. What about type 2 diabetes in India? Is it slightly different? How management of diabetes has changed from until few years ago to now? The realities with the traditional management regime versus the present ones. What are the current Indian glycemic targets? How we need a complete professional team and step care approach to achieve these targets. We look at the recommendations coming from the Indian societies, and we'll briefly look at what precision medicine in diabetes is. So essentially, it's very difficult in a vast country like India to manage chronic care, particularly when we do not have very structured levels of offering care, particularly on a chronic care basis. So acute care is often more structured, but chronic care is difficult for a variety of, and healthcare professionals often to de-intensify because diabetes is not a very symptomatic. We see a complete contradiction that India, amongst countries, has one of the largest populations of diabetes in India. So we have a large population, but we do not necessarily have a structured and unified care. Also, we know that diabetes is a progressive disease. It's not like, say, hypothyroidism, where treatment, a particular form of treatment will remain effective all through life. But here, things are different at diagnosis. Things become different, say, 5 years or 10 years later, when complications seem to occur, like cardiovascular disease, liver disease, chronic kidney disease, and so on. And ultimately, in a chronic care scenario, quality of life also becomes very important, because it's not the insurance which pays for care, it's mostly from the patient's own pocket. So all these factors, and as the diabetes is progressing, the diabetologist or the treating physician needs to take all these into considerations when charting out a prescription for the patient. There are several challenges for type 2 diabetes in India. One, of course, is the huge numbers. There are many genetic and environmental risk factors, not just to say that there are very few areas where people can actually go and exercise. The diet of people is changing, the activity is reducing, stress is on the rise, particularly in societies in the urban areas. There is a marked increase in prevalence of diabetes among young people, and this seems to be slightly different from diabetes occurring in the more elderly, where in these young people, you see significant amounts of not just insulin resistance, but significant amount of insulin deficiency. Diagnosis is still delayed, or if it is diagnosed, still ignored because of the asymptomatic nature of disease and trivialization of the diagnosis from a lot of social media platforms and WhatsApp and all kinds of non-scientific platforms. So the disease awareness among the public is low. Public healthcare facilities are less. We don't have the kind of abilities that Europe has. The cost of diabetes management, although the drugs are cheaper in India, it's a lifelong disease, and therefore it's a lifelong recurring cost. And of course, this all leads to suboptimal diabetes control and obviously rising rate of diabetes complications. So all of this together is worrisome. And we look at the Indian figures, we see here that if you look at the overall population, we see that HbA1c control is seen in barely 30% or less of the population. Blood pressure in about 50%, and total cholesterol or LDL cholesterol in roughly only about 40%. So if you take the composite endpoint of HbA1c, blood pressure, and cholesterol, which is very essential for preventing long-term diabetes complications, you will see that very few people, less than 50%, will have a composite goal that is achieved consistently. And particularly if you look at HbA1c, this is abysmally low. And ultimately, since diabetes is predominantly a disease of sugars, it is very important to control at least the sugars. Although, like Professor Antonio said, it's not only the sugars which carry forward the complications, it's also blood pressure and cholesterol and a number of other factors. And we are not doing so well if we look at all the figures. Also, the phenotype is uniquely predisposed to development of type 2 diabetes, also because of lifestyle factors and genetic factors and the sedentary physical habit. And there is a tendency, therefore, to develop diabetes, a typical type 2 obese diabetes at a younger age, but at a lesser level of obesity. Because although Indians may not look very fat, they still have a marked increase in body fat percentage. And therefore, they may not be called obese, but they are adipose. And we call this typical Asian Indian phenotype the thin fat Indian. So they may not look very thick or fat, but they do have marked increase in body fat content. Management of diabetes until a few years ago was typically directed only at blood sugar control and HbA1c control. And that meant that you could just choose drugs randomly. And this, of course, was known as the glucocentric management of diabetes. And this has completely changed to now becoming more patient-centric, meaning individualization of treatment, which means you'll have to identify right at the beginning, what are you dealing with? Are you dealing with an obese, insulin-resistant patient with mild diabetes in the elderly age group? Or are you dealing with a young patient with very high fasting sugar indicating significant insulin deficiency? What exactly is it that you're dealing with? And then you need to set down the targets for this. So target of HbA1c may not be the same for a 25-year-old patient as opposed to a 75-year-old patient. And this also depends on the number of comorbidities that are also present in that patient. So a person who has very advanced cardiovascular disease one would be a little careful in rapidly enhancing or accelerating treatment. Also, we now know that since the beta cell needs to be preserved as long as possible so that fluctuations later minimize, we should be looking at therapies which so those which try to reduce the stress on beta sensitizers, drugs like GLP-1, SGLT2, and certain gliptins which do release insulin, but in an ambient, but dependent on the ambient glucose. If you look at the traditional management regime, obviously the management, as I said earlier, was quite random. And already at that point of time, the 50% of beta cell function has already been lost. And if you look at what is required, we now know that if you go by the traditional method of just diet and then exercise and just one metformin, then another drug and so on and so forth, you waste a lot of time or a lot of inertia in trying to get to control. So the realization that polypharmacy may be required pretty early to meet glycemic control is very important. And the first 5 years of diabetes really set the tone for all the later complications that are bound to occur. So monotherapy is often now not the standard of care unless you feel that lifestyle alone is bound to have a very significant impact right at the onset of diabetes. At that time, maybe monotherapy is fine. But once you see that sugars are not getting controlled, we need to accelerate very quickly. The glycemic targets that have been set for India are no different really than what is recommended in the West. And Dr. Antonio made a very valid point about the 1 hour postprandial sugars. And I think this is particularly very important when we are dealing with diabetes in pregnancy, because pregnancy and diabetes is typically a problem of postprandial sugars. And it's the 1 hour sugar which often correlates best with neonatal outcomes. This is a very complicated wheel, and I am not going to go too deep into this because it will take a long time to explain all this to you. But what it basically means is that, you have several drugs with you with which you can treat diabetes. Therefore, you need to use these drugs carefully and in a structured fashion, taking into consideration a lot of things. What is the age of the patient? What is the BMI? What is the kidney status? What is the duration of diabetes? Which means, will he require more insulin producing drugs or more of sensitizing drugs? What about established CVD or high risk of CVD? What about the economic status of the patient? What is the HbA1c today that you need to get down? So what is the glycemic status? For example, if you're dealing with a HbA1c of 10, if you say, I'm going to give this patient only alpha glucosidase inhibitors, it's not going to work. Or with an HbA1c of 9, if you say, I'll give him only metformin, it's not going to work. So all these things have to be kept into consideration, and then you have to appropriately plan your therapy. Now, metformin, for a variety of reasons, yes, can be initiated in combination with lifestyle interventions at time of diagnosis. And then, of course, depending on where you go from there, you will have to use other drugs very wisely based on a number of facts that I already mentioned. And this was the initial way in which we used to treat patients. So starting with diet and exercise, then metformin, and then second often was sulfonylureas because it's cheap and commonly available and pretty effective. But that may not necessarily be the case because DPP-4s have come up in a big way, and they have almost the same efficacy as sulfonylureas with less hypoglycemia and weight gain. So maybe they become the second agent. And then you move on to triple therapies, quadruple therapies, insulin, as and when it is particularly required. Insulin is still being very underused. And it is now a fact in India that less than 40% of people who actually require insulin are talked or insulin is discussed in less than 40% of people who require it. And even if it is started, acceleration of therapy, titration, is done in very few people. So there are not just insulin as an injectable agent, but we also have GLP analogs, and these are excellent drugs now, particularly when there is a high risk of CVD or established CVD. But of course, there is a problem of cost. And of course, when we are dealing with a patient, the most effective management requires that you make it an interprofessional approach, not just with a nutritionist and an exercise therapist, but I will also add here a psychologist, because diabetes distress and depression are extremely common in diabetes, and they often add to the worsening of diabetes or non-achievement of diabetes goals. And I'm not going to talk about this slide because this slide is really based on the ADA guidelines. So what really the thing about treating diabetes in a structured manner is, we will just come to the modern method in just a while. But let me tell you, there was often a thought. The traditional method was, as I said, diet, exercise followed by one drug. If that fails, second drug. If that fails, third drug. And we have realized over a period of time that this wastes too much time and the patient remains uncontrolled for a very long time. And the VERIFY trial was the one which actually said that combination therapy right at the beginning of diabetes, even when the HbA1c was between 6.5 to 7.5. So traditionally, they would be only on diet, exercise, or just metformin. Now it is said that if you use combination therapies right at the beginning, the chances that you will get control and maintain it durably over a longer period of time is much more than using a step care approach of adding one drug at a time. So this is, I think, very, very important. And it becomes particularly more so where follow-up in India is not so good at all. So the six most important actions for the physician is strive for early detection and diagnosis of type 2 disease, engage with patients so that they are very clearly aware of what their targets are, initiate timely combination treatment. Now the combinations could be a variety of combination based on your patient profiles. It could be sulfonylurea with metformin, it could be metformin with DPP, it could be metformin with SGLT2, it could be metformin and pioglitazone, it could be metformin and GLP-1, or even metformin and insulin. Regularly measure HbA1c levels and always use multidisciplinary team. And very importantly, because diabetes is asymptomatic, explain the benefits of early intervention to the patient and tell them that don't act, penny wise and pound foolish. Start right at the beginning so that you avoid major complications later. What is all this precision medicine about? Precision medicine basically means that you use the correct therapy for the correct patient. That means you collect all information about the patient. As I said earlier, diabetes is not one single disease. So there could be thin patients, obese patients. There could be rich patients, poor patients. They could be elderly and young. They could be those in the reproduction era where they could become pregnant versus more elderly. They could have osteoporosis. They could have non-alcoholic fatty liver disease. They may have cardiovascular disease. They may have CKD. They may have retinopathy. They may have some other problems, or they may be at a severe risk of reasons. They may have autonomic neuropathies, and of course, economics. And all these, when combined and you think through this, what you come to is called precision medicine. And for that, you also need to have a good record of the patient's data. So I know that electronic medical records are not used by all and sundry, mostly in tertiary care, but do get into the habit of at least putting down a few notes of your thoughts when you first see the patient, making a plan of action as to how you're going to proceed when you next see the patient, whether he's controlled or not controlled. By doing this, you obviously give more personalized care, a better control of diabetes, and a much better quality of life. One example is what Dr. Antonio showed you, that when you look at diabetics now, you just don't randomly start them on drugs. First, see if they have CKD or ASCVD. If they do, your first agents of choice always are GLP-1 receptor agonists and SGLT2 inhibitors. I would say not even metformin. Metformin can be used, of course, but one of these two drugs has to be in place because there is major evidence that they change the outcome of these complications. And for the other group, the remaining group who comes to your clinic and who just needs glycemic control, you still need to be aware that you need to prevent weight gain, you need to prevent hypoglycemia, you do need to take care of their expenses, and you still need to get them under control. And there you have a combination of all these other agents. If you use them wisely, along with an interprofessional management approach, I think treatment of diabetes will become much easier and much more target-based, and we'll be able to provide complications of diabetes. Thank you very much.
Well, thank you very much, Dr. Uday Phadke sir, for the enlightenment of the presentation. Yes, it was very well explained session about the Indian phenotypic patients and utilization of various anti-diabetic drugs in those patients based on the precision medicine approach. Well, with this, we would like to have some questions. So first question will be to Dr. Antonio. So what are the factors which is responsible for therapeutic inertia from healthcare perspective and the patient perspective, and how to tackle them, the strategy for them?
Oh, this is a very long story. You know that I very often the more guilty are the physicians, because inertia mainly, honestly, is sometimes due to the approach of physicians to the problem. I think that this is more related to difficulties of managing not diabetes, but to managing the let's say the number of people with diabetes. I don't know in India, but also in Italy, where I work, we have, let's say, 10, 13 minutes for patients to spend for the visit. And I'm sure that India is no different sometimes. So the time is really limited. The time you can dedicate to the patients is a huge limit. And I believe that this is the first factor affecting the inertia from physician point of view. For the patients, it's a little bit more complex, as my Dr. Mohan underlined. We should need a psychologist on board. Okay. Diabetes is very complex process, because you have to live with the disease all the life. And you are required at any time of the day to make an action. You cannot eat, you must move, you must take medicine. So it's very complex. And it's why very often the patients say, okay, I will relax a little bit, because it's very difficult to face all these tasks all together. So I think that, yes, you should need more time from physician side, more psychological effort to improve the adherence to the therapy.
Okay. Well, thank you, Dr. Antonio. We also would like to listen from Dr. Uday Phadke sir, the therapeutic or clinical inertia by the patient side. Well, we do understand there would be different opinion based on the Indian patient's concern.
I lost your voice in between.
Okay. Well, clinical inertia by the patient perspective. So how to tackle for it will be beneficial to those attendees who is going to treat their patient, provide an insight on that.
This problem is very difficult in India. And I think there has to be a very concerted efforts on social media and by very prominent personalities to set right the myths about diabetes. For example, let me tell you, vaccination program for polio was taken up in a very big manner, and people had a lot of, myths about vaccinating themselves, particularly small children. And when people like sports persons and theater actors and cinestars came to the fore and started repeatedly saying that this is good for you, safe for you, people did accept because these are influencers. Just doctor saying that your diabetes needs to be controlled makes an impact, but that impact is very quickly washed away when they go out into the society and 10 people from somewhere tell them that this is all bunkum and all these drugs are bad for you and it's not necessary, etc., etc. So I think this unification of a structured program. Also, I think if insurance comes in a bigger way,
Right.
care becomes more organized, because insurance will always not accept poorly controlled patients, or they'll charge them much more heavily. So it's like an incentive now that if you control your diabetes better, your premiums will also be less. So I think there is to be a concerted effort by influencers to make sure that people understand the importance of diabetes. People, when we talk to them in the clinic, we tell them, don't look at unvetted posts circulating on media. And I think somewhere, if the government steps in and makes a national program for control of diabetes, like they have done for, say, now COVID, there are strict guidelines. You can't just do anything that you like. It might help considerably. Although it's a big ask because numbers are too huge and there is no unified program. You know as well as I do that there are different types of doctors in India. There are some who are trained in the modern medicine, and there are a lot of people who are trained in the alternative forms of medicine, and care is not the same. So it's very difficult right now. So we do make an effort through our programs to reach out to them and explain the benefits. But it stops there. We are still not able to do it for a large majority of people.
Right. So these are the challenges from the patient side, because the social media is playing the role which is diverting their mind from taking the adherence of the treatment, where they require continuous efforts to create a good policy, I guess, by the government side. So I clearly appreciate Dr. Phadke sir about your opinion about the clinical inertia by the patient side and how should be done. Well, the next question about the glycemic variability. Nowadays, it is one of the important concern about the patient who are on polypharmacy. So what are the step care approach in the glycemic variability?
But first of all, you need to know, and probably, I think that CGM in a medium short term will be more and more available. It's like the mobile phone. No? At the beginning, it was very expensive, and then the cost was dropping when many people were using. Because clearly, to avoid variability, you need to know what happens, first of all. And second, as intervention, not only you have good drugs, as I briefly described very quickly, but there are some drugs more active on this variability, but also a diet intervention could be very helpful. Yes. You avoid, let's say, glycemic index. I think that this for India is very relevant. No? High glycemic index food should be avoided, and also in this way. So there are strategies you can avoid, but first of all, you need to measure to know what is happening.
Yes, Phadke sir, do you have?
I completely echo what Dr. Antonio said. Okay. Diet is very important in glycemic variability because most of our peaks are seen in the postprandial phase. And the diet genuinely needs to be modified. There's no question of it. We need to cut down on carbs and high GI food. That will itself cause significant reduction in high peaks after meals.
Okay. So next question to Dr. Uday Falke directly, sir. Well, there is a new phenotype type you have just mentioned in a presentation, thin fat Indians with the type 2 diabetes. So it has been said or mentioned in the guideline as well that early initiation of combination therapy. So what is so whether it have any impact on the weight and further the complication, diabetes related complication in thin fat Indians with implementation of combination therapies?
So combination therapies is, so what thin fat Indian means is
Right.
that although you may be looking thin, you're still very much obese. So your management still has to focus as reducing body fat, which means you'll have to use therapies, if affordable, like GLP-1 analogs, like SGLT2s, because they are the ones which will reduce body fat to some extent, apart from, of course, diet. There's no question about diet and exercise. Also, the genotype studies in India say that although these people are insulin resistant, there are also a lot of genes, and in fact, a majority of genes studied in India are actually related to insulin secretion. So we are not just insulin resistant, we are also insulin deficient. So when you say we are resistant, that's just one part of the story. We are also not making adequate insulin. And this has been seen even in the stage of IGT in Indian patients. Therefore, these combinations of gliptins and metformin often work very well in Indians because they address both these modalities at one go rather than doing it sequentially. I'm not advocating that each and every person go on to a combination therapy. But the moment you find that this is not working, please accelerate quickly, is what I'm saying. Don't wait too long, because polypharmacy is needed in diabetes, except for a few people who can stay on one drug or two drugs. Otherwise, more drugs are required.
Okay, thank you, sir. So we'll have a couple of questions, two more questions. Nowadays, the beta cell preservation with type 2 diabetes is more important. So how initially in a newly diagnosed type 2 diabetes patient, implementation of that treatment is crucial or not? Dr. Antonio, I would like to listen from you.
It's the key. Early intervention is very, very important in order to preserve beta cells from the glucotoxicity, because this is one of the story in the beta cell damage the first phase. You know, there are studies showing that coming from China essentially, but also from the States, that when you have the diagnosis, if you start with insulin, you can stop any treatment after a few months because you can preserve beta cells and they will rescue somehow. The concept is that early treatment, intensive treatment, is not only relevant for the risk of complications, you know, the legacy effect of hyperglycemia and so on, but also for the effect, for the possibility to better preserve beta cell function.
Well, that is the one scenario where you're talking about the implementation of insulin to have the beta cell preservation. But nowadays, the new concept is coming with the improvement in the mitochondrial function that also will focus on the beta cell preservation. So which oral hypoglycemic agents will be preferred in the early phase of the treatment?
Oh, from my side, I honestly, if you look at the mechanism, one of the best probably is metformin, because at the mitochondria it works very well. But clearly the problem is that it's not enough to also control glycemia. And I completely agree. I have already also published this, that the combination, very early combination, is a solution, because you cannot take let's say we are speaking about the octet, no, in the pathogenesis of diabetes. And you believe that one drug can take all the 8 pathways? It's almost impossible.
Impossible, yes.
So you need more drugs. I understand that the particularly many physicians and the patients are very reluctant to use more than one drug, even two drugs, but this is the solution. There is not an alternative.
Okay. So do you have any different opinion, Dr. Uday Phadke, sir?
I think at the beginning of diabetes, one of the important ways of reducing load on the beta cell is to lose weight. And if you instill a diet which is low in calories, immediately the beta cells are put to rest because they don't need to work to produce more insulin. And this had come out very beautifully from the direct study, where if you instill a diet of 900 calories, you will see rapid improvement in HbA1c's, weight for a large majority of people. So I think right at the beginning, so diet after 20 years of diabetes doesn't work, but it works beautifully in the beginning of diabetes. And probably you're also referring to certain drugs which change the mitochondrial energetics like imeglimin. However, let me tell you that currently to recommend imeglimin as first-line therapy for diabetes would be a tall order. We still do not have adequate data on long-term outcomes. But yes, it's an interesting concept. It's one of the drugs after metformin which changes the mitochondrial electron chain handling and will be a useful drug in the future. And people are also looking at effects on the heart, contractility with drugs like imeglimin. But right now, I don't know whether it should be the frontline drug over and above what has been tested for so long and which has gone through the randomized controlled trials.
Okay. Clearly appreciate your opinion. Yes, imeglimin nowadays came up with the new concept about the mitochondrial dysfunction and early implementation in the type 2 diabetes. But yes, data is not adequate. So yes, we shall wait for that. One more question, that nowadays in insulin, in type 2 diabetes patient who are on insulin, oral hypoglycemic agent also prescribes. So how many oral hypoglycemic agent is adequately prescribed? What would be the exact number and what are the step care approach for that?
Should I don't think that how many. It's very complicated to say because also it depends on the specific patients you have in front. Maybe if it has a high risk cardiovascular risk, then you prefer some combination. If not, you prefer something else. Now we are also to face a NASH, and then it's very complicated. Why I agree that an earlier use of insulin probably is also important more than.
So let's say a patient would be the candidate of cardiovascular risk and kidney risk, who is having the more than 10 or 15 years of diabetes complications. So where insulin is required, but oral hypoglycemic agent, patient were on a earlier oral hypoglycemic agent. So, but which newer anti-diabetic drug would be more beneficial in that scenario?
I do not have experience with imeglimin because it's not in the market in Europe, of course. But also we should be a little bit careful when we are adding an SGLT2 because on insulin, you can increase the risk together with insulin. You can increase the risk for ketoacidosis if you are not able to manage in the right way the insulin dose. A combination with GLP-1 receptor agonist is already better established and also has a cardiovascular prevention. So probably more than anyhow, it's much better to switch not an oral but an injectable, meaning that combination of insulin GLP-1 at the moment, for the evidence we have, is more easier and acceptable to use.
Yes. So, Phadke sir, do you have any different opinion? This
is a very difficult question to answer in a line.
Yeah.
But yes, as he said, SGLT2s probably and GLP-1s. But it also depends on what level of control you're looking at when you add insulin. If your HbA1c is 11 and 12, obviously all the drugs have failed. There's no point in keeping them. You just use insulin. But if your HbA1c is 8 and you're adding some impact, so I would keep them right now.
Okay. So
And
yes,
maybe
definitely
withdraw them later. It's a very individualized. So the concept of keeping orals and just using a basal is very much in vogue. So I think it is very individual as to what you would do with the drugs. It will
Yes.
depend on the level of control and other things.
Well, that is a individualized approach, I guess. Yes, definitely. So last question, and with this we will finish this session. CGM use in type 2 diabetes management.
I can answer. We had just a meeting for a new consensus last month in Berlin, Germany, with many people from all around the world. But what is really relevant is that were there also ADA and ADA, ESD, FDA, and EMA, meaning that the question of the use of CGM in type 2 is really relevant and maybe is the next step.
Yeah. Is it relevant, or we need to implement that thing?
The consensus is going on, but probably, yeah, first of all, the type 2 on insulin, there is no discussion, it's very useful. But what we were discussing is useful also in type 2 not on insulin, particularly at the diagnosis in order to improve the early treatment. And the answer is yes, according to literature, but this process is ongoing. But what is interesting that are involved not only scientific societies, but also, let's say, public healthcare, let's say, bodies like the FDA and EMA, European Medical Agency. So,
great. Well, yes, we shall be waiting for the consensus to publish so that we will get the detailed information about the CGM in type 2 diabetes. Well, thank you, Dr. Antonio, for your wonderful insight, and definitely that will help our attendees to to take care of their patient and improve the quality of life with the type 2 diabetes as well as type 1 diabetes. With this, I would like to conclude the session and hand over to Mr. Sumit Khedkar for the thanks and closing remarks.
Well, thanks, Dr. Kunal, and my sincere thanks to Dr. Antonio and Dr. Uday Phadke, sir. It was really very interesting, and it could be visible through the extended time. And Dr. Kunal had many more questions, but he could curtail to a few of the questions, though this has taken us beyond our time limit. But I really appreciate and sincerely like your approach that you have addressed all the queries in depth. And I'm sure for all the audience, this was a very interesting discussion on the learning curve, and would take it forward in their respective practices. So once again, from Lupin side, I thank to both the eminent speaker for taking your time and all the attendees for attending this wonderful scientific session. So thank you once again, and do take care.
Thank you once again. Take care.